anything in particular kind of stand out to you when you looked over those 2022 SAMHSA numbers?
No, I don't think it really surprised me. If you look at the numbers, the biggest impact I think over the last several years has been COVID and the isolation. Isolation was just disastrous for anybody with a substance use disorder of any sort, really. It just gave them, permission to kind of dive further down that rabbit hole.
It's interesting you bring up because Chris, we were actually talking about that specifically with some of those adolescent depression numbers. You would have to imagine that those numbers were so high because of everything involving COVID. Specifically, though, I know one of the main reasons why you're joining us today was to kind of get into some of the specifics as far as the fentanyl numbers were concerned. So, just diving straight into that, the first question was, so over the past 2 decades, how have approaches to treating addiction, particularly opioid use disorder, evolved? And then can you kind of give us a little insight into some of the most significant changes or advancements when it comes to opioid use disorder, and then within that fentanyl as well?
Sure. We've certainly had to get better at our treatment of opioid use disorder. If you look back at over the past, say, 50 years, back in about 1971 is when methadone clinics started. Okay. And initially, prior to that, the only thing we could do is load people up on lots of clonidine in the hospital. And basically they had such low blood pressure, they couldn't walk, they couldn't get out of bed, their mouth was really dry. And it was, in order to allow them to, quote, kick it, unquote. So certainly the methadone clinics were a start. And that could only be done in opioid treatment facilities. And then in about 2002, we got Suboxone, and buprenorphine came online with the Data 2000 Act. And so certainly that was a huge benefit. Since then, we've figured out, just better ways of, giving the Suboxone. Certainly with COVID, there's been more lax rules about methadone take-home doses. So just lowering the threshold or lowering the barrier to treatment. That's been the biggest change lately. And certainly now we've got once monthly injectable buprenorphine in the form of Sublocade and Brixadi. So we continue to get better, and we have to, because the problem's gotten worse.
Absolutely. So when you kind of take fentanyl not out of the equation, when you separate it from opioids as a whole, in what ways does fentanyl usage specifically present challenges when it comes to treatment that you may not see when it comes to treating, say, more traditional types of opioids?
Well, historically with, say, oxycodone, which was the last, big push along with heroin prior to fentanyl, certainly you had a very fixed amount of time that someone would have to be off of it before you needed to start, buprenorphine, Suboxone. Certainly they could get on methadone right away, but really what's the challenge has been in the induction phase, so that the Suboxone can't be added on as soon as, say, with oxycodone. Oxycodone, 16 hours after their last dose, they could start Suboxone and they'd never have precipitated withdrawal, which is like withdrawal times 10. So with fentanyl, it sits in the soft tissues, and so it hangs around for longer. Even though it's not getting, someone high for longer, it sits in the tissues for longer, and it's still a longer drawn out problem for precipitated withdrawal. So people have to get further into normal withdrawal before you can start medications like buprenorphine. So that's been trickier.
Absolutely. So beyond just that, are there specific strategies or methodologies that have emerged that can kind of help treat fentanyl addiction more effectively, or more, more effectively, I guess you could say?
With the induction, we've had to get more creative as as an addiction medicine treatment population, so that, we've come up with something called low dose or microdosing, low dose buprenorphine, having actually the patients continue to use fentanyl while gradually ramping up the dose of buprenorphine in order to get them started. The other alternative to that is have them try to get into moderate to, I guess, moderate withdrawal would be the best way to put it. So 36 hours, say, after their last dose of fentanyl, and then using macrodosing. So using very high doses of buprenorphine and essentially just blast the fentanyl off the receptors and blast right through the withdrawal symptoms. So we've had to get more creative, and every patient wants to avoid withdrawal at all costs.